So this PowerPoint talking about the health assessment and or physical assessment of the adult client. The first of all, environmental and setting. Established a relationship to explain the procedure to the client. So when a patient comes to me, I'm the healthcare provider, I will make a good, comfortable relationship. It is called nurse-patient relationship or doctor-patient relationship. It is very important. If your patient not feel comfortable with you, they will not share their story. When the patient does not, or when patient do not share the story, you will not get a proper medical history. If you do not get a proper medical history, you do not go for the assessment. And when you do not get a history, do not get a proper assessment, how you will diagnose the patient? We call it nursing diagnosis. We will not. So the first steps, communication. And communication based on remove all of the barrier of communication. And first steps is established a comfortable relationship with the patient so that patient can verbalize their feelings. And always what you are going to your patient, it is good to explain step by steps, right? Procedure to the client. Ensure the privacy and make the client feel comfortable, right? Comfortable about what? About the provide a comfortable room temperature and sufficient, make sure sufficient lighting there. Imagine you are going to check a patient anemia or jaundice. If there are no enough light, you will not see the patient are anemic or patient are icteric or jaundice. Also remove all distraction such as noise or any objects, and also avoid the interruption. Makes sense. Sit down for the interview and maintain an appropriate social distance and maintain the eye-to-eye level. It is the one of the good communication. So next here, use the therapeutic communication technique and open-end question to obtain the information. So if I ask you, what is open-ended question? Right? Open-ended question means you do not ask anything, patient can say yes or no, why answer. But I said open-end question and therapeutic way of communication is important. So first of all, you have to know what are the blockages of communication. So you have to remove the blockades. Example, I said, you talk a different language, what patient can understand. It is the blockage or blocks. Like an elderly patient came to you and patient has a hearing problem and patient forgot to bring the hearing aid, right? It is the blockage or it's the barrier of communication. Like you ask a question to the patient, but you are not listening. So you hear, but does not actively listen, right? Or sometimes patients say something, you reject it. You ignore the client complaint or response. It is the blocks or non-therapeutic communication. As a healthcare provider, when you interact with the patient, always try to avoid the non-therapeutic communication. So consider religious, spiritual, and cultural characteristics such as language, beliefs, values, health practice, eye contact, and touch. And keep the note taking to a minimum so that the client is focus of attention. Important. Now here talking the type of health and physical assessment. One is complete assessment, focus assessment, episodic or follow-up assessment, and emergencies. What is complete assessment? Include a complete health history and physical examination, and also form a basic database. So when a patient comes to you first, you take a history. History must contain objective and subjective data. So objective data means what you can see, what you can touch, what you can feel, what you can smell, what you can measure. And subjective data means what patient complain. Like if patients say, I have a blood pressure, high blood pressure, you can measure it. So you can measurable, and this is the objective data. But if patients say, I have a nausea, nausea means desire of vomiting. You can't see, right? And this is the patient complaint. This is subjective data. So our history on based of subjective and objective data-based. Also keep in mind, when a new patient comes to you, we have to check head to toe, head to toe. Not only focus a particular system. When patient come for the follow-up assessment, you can focus on evaluating a client progress. What is focus assessment? Focus on limited or short-term problem such as client complaint. Episodic follow-up focus on evaluating a client progress. Like patient came to you with a hypertension and you give them antihypertensive medication. Patient came after 2 months, still patient are hypertensive and blood pressure still higher than before. So in that scenario, you have to add new medication. But before add the new medication, we go for assessment outcome. So what we could do, we always follow the nursing process, right? And I said always we have to follow the nursing process. An easy way to remember, it is called add pie. PIE. So first of all, when patient to come, we go for analysis based on database. We take the history, we go for the assessment, A for analysis, A for assessment, and then we go dialysis, diagnosis, and this is called nursing diagnosis, because this diagnosis on based of patient complaint, subjective and objective data. This diagnosis not on based of laboratory data, no investigation. And after this, we go for planning, right? And after planning, like your patient has a saturation of oxygen is 89%, and you give them oxygen, after a few minutes, patient is going to improve, right? And when you give them oxygen, this is implementation or intervention. After give oxygen, few minutes, when you recheck again by oxymetry, you found your patient saturation of oxygen is 95%, 6%. This is actually outcome, and this is evaluate. After watching the outcome, you go for the next steps. Maybe your patient need to step up the treatment. Maybe your patient need to discharge from hospital. Maybe your patient need to change from one unit to different unit, right? So it is always follow the nursing process. And here emergency assessment involve the rapid collection of data, often during the provision of life-saving measure. Let me give you one example. Imagine you are working in emergency department and you got 3 patients. One patient came with you like bronchial asthma. Another patient came to you with diabetes mellitus, and another patient came to you road traffic accident, and very bad road traffic accident. So the patient who came with diabetes, it is very stable patient. Patient will not die within a time. So first of all, I'm not talking about the priority, which patient you go first. I'm not talking about this. I'm talking about the way you proceed for diabetic patient or bronchial asthma patient. It would be different the patient who came from road traffic accident. Imagine a patient, ribs are broken. Patient is difficulty of respiration. Patient needs emergency operation theater to go. In that scenario, you even do not say who will give the informed consent, because life saving is the priorities, right? So when we go the emergency assessment, I said bronchial asthma or diabetic or any new patient, we have to check from head to examination, right? But when patient is a road traffic accident, we must check or follow A, B, C, D law, right? We have to check first airway, we have to check breathing, we have to see any kind of active bleeding or circulatory collapse. Then we found any kind of disability and remove your patient from the source of danger. So this emergency assessment. What else? Now, history taking. So a good history is an art, basically. A good history help you to go for diagnosis your patient. So here, a general state of the health, family history, social history, it should be included in the patient assessment. So general state of health, both feature and physical characteristics, body movement, body posture, level of consciousness, and nutritional status and way of talk, speech, everything including, right? So what the way of speak or talk, you can see patient has any kind of uh, difficulty of speech, or patient has hoarseness of voice. Maybe hoarseness of voice indicate patient has a hormonal disbalance, nutritional status, undernutrition or obesity, kwashiorkor or marasmus, the level of consciousness, particularly elderly patient, alcoholic patient, or nervous system disbalance, body posture, right? Decelerate or decorticate posture, movement or gait, physical characteristics, under control of their voluntary muscle or not. What are the chief complaints and history of present illness? So chief complaint means why patient get hospital today. Sometimes imagine I have a severe abdominal pain, or I am feeling suffocated. Call 911, get emergency. But why I call 911 and why go to the emergency? Because I felt suffocated or I have a severe chest pain. This is the chief complaint. So in the chief complaint, we have to elaborate in present illness in the history taking. Family history, the health status of direct blood relatives, as well as client spouse. So if your patient are able to give the history or data, it is primary source. Like your patient are not able to give the data, we can collect it from the family members or spouse. So the source of data will be secondary, right? And also we have to take the family history. Like imagine my father passed away because of high blood pressure. My uncle passed away because of cardiovascular disease. So I have a chance to develop same problem, right? So some disease are related strongly with genetics, right? So we have to evaluate it. We have to exclude it. The social history data about the client lifestyle with a focus on factors that may affect the health. The information about the alcohol, drugs, tobacco use, or sexual practice, traveling history, work setting, or identity occupational hazard. Like a patient give a history that is related to the bladder cancer. And when you ask them, patient tell, I work in a dye company for 25 years. Occupational hazard. Because of occupation, patient developed the bladder cancer. Like a farmer have a chance to develop the respiratory problem. So some of the disease related to the occupation, right? And here, health history continue. What are the components of health history? Biographical data, first of all, contain biographical information is often collected during administration to a healthcare facility or agency and documented on a specific forms. It helps to identify the patient. Biographical data include patient name, their address, gender, marital status, race, ethnicity, occupation, religious preference, advance directives, healthcare financing, and also primary healthcare provider. So biographical data must include all of them, right? So I said the occupation sometimes related or cause the disease. Some of the disease are most common in particular race or ethnic group. And like patient came very low socio-economical condition, whatever the rich or poor, we should respect them. We will be fair to all. It is our ethics. But some diseases are most common in socio-economical condition, poor condition, like tuberculosis. When patients live in overcrowded area, maybe the chance to spread up the disease. The rich people, most common the heart disease, right? So sometimes their socio-economical condition also related to the disease. Gender, some of the disease like most autoimmune disease, most common the female, or benign enlargement of prostate is it is in man problem, right? And also geographical areas, like some Asian countries, some people have a stomach cancer is more. So also the reason for why your patient looking for a care. The patient's reason for looking for care helps to focus the rest of assessment, also present an open-ended question, such as, so open-end question and closed-end question. So it is good when you ask a question, it is patient can more verbalized. So when patient is more verbalized, they can feel good and you can get a more information. And always when you ask the question, it will be effective, right? And also after find out the problem, help your patient to coping. It is a part of it. Now health history, including the domestic violence. So when you take the history, if we find any clue of domestic violence, we have to evaluate it. And we have help our patient to give enough resources, supporting groups. So determine whether the client is experiencing any form of domestic violence. Sometimes NCLEX board asks, who is under risk of domestic violence? One is elderly patient, and another is children, right? So out of elderly patient, most common are elderly with Alzheimer or dementia. The conduct during one-to-one interview with the client while obtaining the health history. If you see any clue of domestic violence, it is good to take one-to-one history from the patient. Now, mental status examination. The mental status can be checked while obtaining the objective data from the client during the health history interview. So here talking about the obtaining the subjective data, because patients are complaining, patient explaining their medical condition, and you are listener. When patient complain, it is subjective data. Appearance, how they look like. The alcoholic patient, alcohol abuse, their lookings and one healthy person lookings definitely are not same. Sometimes outlooks can talk. A patient who are struggling for oxygen, like patient has a acute exacerbation of bronchial asthma, you can see them and you can understand this, maybe this patient has a hunger for oxygen. So when you look the outlook, you should make a note. Note the appearance, including their posture, their body build, their body movement, their dress up, their hygiene and grooming. So if the patient, if you take the history in psychiatry department or neurological department, maybe patients are refused of their grooming, their dressing, their hygiene, right? It is very common in that kind of patient. An inappropriate appearance, poor hygiene maybe indicate of depression or manic disorder. Patient sometimes dementia or organic brain disease or other disorder. So the patient who are depressed, you can see most of the times they sad, they apathic, they cry, do not eat, does not follow grooming, does not maintain hygiene, not well dressed up. Suicidal tendencies most common, right? Or their mood is altered. So you ask the patient directly if they have any plan of suicide, if patients are depressive, right? So according to the history, we make the plan for intervention, particularly if our patient has a depressive or manic disorder, dementia, or organic brain disease, always keep in mind, safety is the most priorities. So we provide the safe environment. This is the priorities. Mental status exam also include our behavior, like level of consciousness. Check the alternates and awareness, and the client ability to interact appropriately with the environment. Usually, we have to ask patient about the time, place, right? And also, we should ask something related to recent memories. And we find out the level of consciousness altered or intact. Usually, we could follow the Glasgow Coma scale, the facial expression and body language. Check the appropriate eye contact and determine whether the facial expression and body language are appropriate to the situation. This data collection technique also provide information regarding the client's mood and affect. The speech. Check the speech pattern for articulation and appropriate conversation. Sometimes disoriented patient added the new word, or they use the word salad, echolalia, right? So it is very common with the patient, right? So the speech is important to find out, particularly when you're dealing with the patient is neurological deficit or psychiatric patient. Sometimes you can see when patient talk, they're restless or give the congestion. So also we have to see the patient are dysphonia or neologism is there. What salad is there? Fight of idea. Everything should continue when you talking about the speech. During the mental status examination, we should find out any cognitive disorder present or not. Cognitive disorder including delirium and dementia. So what are the difference between dementia and delirium? Dementia means chronic irreversible syndrome that affect the language, memory, cognition, and personality, even with judgment. But delirium is acute and reversible. What next? They said the mental status exam or cognitive level of function, first of all, contain orientation, assess the client, orientation of person, place, and time. You ask the person who you are. You ask the person, what is your name? You ask the person where you are right now, or what date today. Attention span. Assess the client's ability to concentrate, right? Usually it should be altered. Or recent memory loss. remote memory loss. So about the recent memory, assessed by asking the client to recall a recent occurrence. Like you ask what you ate at breakfast, morning breakfast, or what you ate last night dinner. Remote memory associated by asking the client about the verification about the past events. You ask them, can you tell me what you were born? Or can you tell me what city name you started your school? So also new learning used to assess the client ability to recall unrelated words identified by the nurse, or judgment determine whether the client's action or decision-making abilities regarding the discussion during the interview are realistic or not. Sometimes some of the patient has no relation with the realities, or some neurological patient lost the judgment power, thought process, and perception. Sometimes patient has a delusion, illusion, even hallucination. So that way the client think and what the client say should be logical, right? Should be coherent and should be relevant. The client should be consistently aware of reality. If patients are not coherent, logical, or awareness with reality, it should be abnormal. Maybe patient has a false fixed belief. Maybe patient has a misperception of stimuli, or maybe patient has a sensory perception and there are sensory perception without any stimuli, right? Is also the part of mini mental status examination.